This is an instructional video on how to present a patient in the medical ICU that's already been here. This patient, for example, was admitted yesterday.
Events overnight. A spontaneous breathing trial was attempted, but patient failed because of altered mental status as well as very thick secretions. Afebrile overnight, but no other events reported to us on exam. In terms of physical exam, patient remains afebrile at 37.1, tachycardic mildly to 102, hypertensive in the 130s over 92, and respiratory rate at 28, satting around 94%. In terms of pertinent other physical exam, on cardiovascular, patient is mildly tachycardic but regular rhythm, no murmurs on exam, peripheral edema has improved, only traced to 1+ on exam, as well as on respiratory, she has fine crackles throughout both lung fields, and then no other pertinent physical exam. Labs were significant for a mild leukocytosis of 12.4, hemoglobin 8.6, mild thrombocytopenia of 140, and BUN of 32 and creatinine of 2. In terms of imaging, chest x-ray re-demonstrated the bilateral interstitial infiltrates as well as the ET tube in place. So for assessment plan, we have a 72-year-old female with HFpEF, hypertension, CKD, and hyperlipidemia and diabetes who presented with cough, fevers, chills, as well as hypoxemic respiratory failure, status post-intubation in the ED. So for neurology, we have acute encephalopathy, likely secondary to sepsis, and possible component of uremia. We will attempt to wean sedation as tolerated for daily sedation holidays to try and get a better sense of her intact neurological function. For cardiac, we have HFpEF. Patient appears more euvolemic on exam, so we'll hold the Lasix for today. For the hypertension, patient is on amlodipine 10 as well as carvedilol 12.5 milligrams BID. For respiratory, we have acute hypoxemic respiratory failure secondary to influenza A, as well as possibly a presumed secondary bacterial influenza or bacterial pneumonia. We are continuing the ceftriaxone and azithro as well as the Tamiflu for our 5-day course. Blood cultures are negative growth to date, as well as Legionella and strep urine antigen became negative. For the pulmonary edema component, we are holding off on further diuresis as patient seems more euvolemic on exam. For GI, no acute issues. For renal, AKI on CKD, her creatinine is slightly up from her baseline of 1.8 on presentation. We're holding off on further diuresis and following urine output throughout the day. For infectious disease, as we talked about, we have community-acquired pneumonia as well as influenza A. Patient is on ceftriaxone and azithro, as well as the Tamiflu for a full 5-day course. Blood cultures so far have been negative. For HEMOC, we have normocytic anemia, no active bleeding noted on exam. We'll transfuse for hemoglobin above 7. For the thrombocytopenia, most likely secondary to sepsis induced, we'll continue to monitor and transfuse for platelets above 10 or above 50 if she's actively bleeding. For endocrinology, for her diabetes mellitus, sugars have been well controlled in patient for a goal 140 to 180. We're continuing the medium dose sliding scale. So for our checklist, we have feeds. Patient is on Glucerna 1.2 at 50 cc's per hour. For fluids, none. For activity, she's intubated and sedated. For DVT prophylaxis, we have her on heparin sub-Q TID. For GI prophylaxis, she's on the famotidine, now daily because of renally adjusted. And for the glycemic control, she's on the medium dose sliding scale.